But in these young PSSD kids on these SSRIs at a very, very young age, often before they had any idea, or even the parents had any idea that there could be this issue of PSSD, we're seeing their tissue as if they're 70 years old. That is the most crazy and remarkable thing. They have tissue damage of their penis from the tissue near the glands, from the tissue in the midshaft, from the tissue at the base, from the tissue in their crus. And it's not just the tissue change; it's the severity of the problem that is an issue. Listen, let me just say, I'm not against SSRIs. Okay. In appropriate situations, they save lives. There's no question. I think where I fumble with medical professionals is their inability to provide warning, like appropriate consent. It's not that complicated to get this medicine anymore. So people who have situational situations, who should be counseled, are getting these dangerous brain-altering chemicals that can affect tissue integrity for the rest of people's lives. It's crazy.
Hi, Dr. Goldstein. Welcome. Thank you so much for coming on and speaking with us today about PSSD. For the people out there who don't know who you are, could you please just provide a professional background briefly?
Golly gee. I'm a board-certified urologist, former biomedical electrical engineer, and former college and medical school hockey player. I am born in Montreal, Quebec, Canada. I moved to Providence, Rhode Island, and Brown University to start my sort of college and athletic career. I went to McGill Medical School for medical school work. My wife, who I met at Brown, moved with me to Montreal. And we then moved to Boston, spent 25 years in Boston, and moved to San Diego 17 or 18 years ago. And I'm a urologist, but I don't really do urology. I've sort of used the title to focus in on the field called sexual medicine. And sexual medicine is a field where we are a subspecialty of all of medicine, and we focus on the study, the diagnosis, and the treatment of men and women with sexual health concerns. And without realizing, men and women who have been on selective serotonin reuptake inhibitors for mood disorders change the brain chemistry, and when they get off their selective serotonin reuptake inhibitors and have usually experienced some sexual dysfunction, are usually told that they don't have to worry because whatever they were prior to the SSRI use and sexual function will return in sexual function, but it's not always the case. So the persistence of this selective serotonin reuptake inhibitor sexual dysfunction is the term PSSD, and we're bombarded with patients with this issue. So this is not a subtle thing. This is a very, very common occurrence in our practice.
Let me ask, when did this, when I first heard about this, I was kind of shocked that something so serious could happen and so life-altering could happen from a medication that is really viewed as quite safe and benign. When did this issue first come to your attention?
So, like everything in medicine, when you're not looking for it, you don't see it. And when you just say, I don't understand why everyone is told all their symptoms of dysfunction will go away, because we're not seeing that. We're seeing a lot of people where it continues, the sexual issues. And it's a little ironic that most users of SSRIs are women, but most of the people we see are men, because I guess, I'm just guessing why we see that, but it could be that men aren't tolerating the sexual dysfunction and women are just saying, it's just another thing I endure and bear and sometimes have to do during the week to keep my partner, and I'll mate guard, but on the drug it was awful, off the drug it's even more awful, but I'll just deal with it. Whereas men, it affects many aspects, but erectile dysfunction is particularly annoying. And among many things we do is we do very specialty examination of people with erectile dysfunction. So over time, it just became so odd. We were seeing these people on multiple different SSRIs, Prozac, Lexapro, and Zoloft, whatever, any one of them. But they were given to them at 18 years of age. I have people at 12 years of age, and people at 8 years of age for anxieties at school, God knows why, but on it. And they're now entering puberty, and they want to masturbate, and they want to have sex with partners, and they can't do that, and nobody can figure out why. And the crazy part is when we actually get them to the office and we do the objective evaluations of what is going on with their sexuality. We have a biopsychosocial examination. It's a 3-hour visit. I spend an hour with them in history and education, and we do an hour of testing along with an hour of psychology assessment. But that hour of assessment, biologically, we inject a needle in their penis, they get an erection, but their average age is in their 20s, and I see many, many men in their 50s, 60s, and 70s. That's our usual population with hypertension, high cholesterol, diabetes, cigarette smoking, all the risk factors for vascular disease. And for them, we have a very fancy 15.4 megahertz probe ultrasound device, and it has amazing resolution at very limited distances of the application of the probe to the testing site. The usual ultrasound is here's the woman's body, here's her pregnant abdomen, and here's where the probe is. You don't need a very expensive ultrasound because it's focusing many centimeters away. But for an erect penis and an ultrasound, you got to have a fancy probe. So we have that fancy probe. And here are these 20-year-old kids who, when we normally see kids with erectile dysfunction, it's based on, gee, when I was having sex with Mary, she came down on me, my penis broke. Or I'm a bicycle rider, and here's my crotch, and the bar is jamming into me, the seat is jamming into me, and I know I've hurt the bottom part of my penis. Or it's very traditionally a trauma. But in these young PSSD kids on these SSRIs at a very, very young age, often before they had any idea, or even the parents had any idea that there could be this issue of PSSD, we're seeing their tissue as if they're 70 years old. That is the most crazy and remarkable thing. They have tissue damage of their penis from the tissue near the glands, from the tissue in the midshaft, from the tissue at the base, from the tissue in their crus. And when we take control people with 70 years of age and hypertension, high cholesterol, and I look at their ultrasounds, and I take the other control people who are 20 years old with obvious trauma, breaking their penis, jelking injuries, putting constriction ring on, putting weights on, very obvious trauma injuries. They have a way different ultrasound appearance. Our kids with PSSD have the same pictures as older people, and there are data in the literature that if you take animals and you feed their water with sugar water, and you feed their water with any versions of SSRIs, and you cut their penises off months later, being constantly exposed to these SSRIs, you induce tissue damage. The basic mechanism is generation of what is called oxygen radicals. So oxygen is O2, and it's just it's in the environment. We breathe it every day. But O3 minus, which is the oxygen radical, is a very intense molecule that adheres to smooth muscle cells in the penis, that causes tissue damage and apoptosis, cell death, that leads to scarring. And I think that's the way these poor kids have these ultrasound appearances as old people. Their tissues are, for whatever genetic reasons they're susceptible to these drugs, they are susceptible to these drugs. They have tissue damage that's way above and beyond logic and rational explanation. That's really scary. I mean, it is really scary. I have a 22-year-old and was just with yesterday on Lexapro as, I don't know, age 15 or 16 for various mental health issues. He's trying to be in a relationship with someone. I have the need to inject his penis with the most strong drugs. We have like 15 different drugs. He's on the upper end of the spectrum, and he hardly gets an erection. And he looked at me in tears and says, "I'm never going to have sex. I don't want to have sex. This is the most awful thing that has ever happened to me." And I said, "No, we have lots of things to help you with. But I mean, you really have to work with me because this is bad." And he was not prepared for this finding. And so to deny PSSD, hey, people deny the Earth is around and travels around the sun. That's fine. People deny Holocaust, and I guess that's not fine, but they do. But I mean, that's just our scientific finding.
What's happening? What's happening with health regulators? I guess groups like the FDA and EMA, who look at this data where you have, we
haven't published it yet.
Okay, all right.
It's 2B. We're working on it. It's taken 3 years. With COVID, it kind of interfered with all this, but.
Okay, and
I think you're speaking to the head author of this at some point in the future.
Is that Ahad?
That's Ahad, yeah.
Yeah,
he's cool.
Yeah.
He has lucked into an amazing project. Wow.
Hey, just want to interrupt quickly and just say if you're enjoying the content that we're producing here, that you consider liking, subscribing, and commenting on the videos. These are the type of things that gets this video kind of pushed to broader audiences, and it can really help us.
I mean, this is really going to be pretty groundbreaking. I mean, when this comes through, could you give me a sense of how big is the cohort of, I guess, people with PSSD who have had these tissue changes in the penis? Just a sense of the sample size there.
I mean, we're obviously a facility where people come to us with persistent problems. If you're able to travel to San Diego and undergo these tests, it's what we see. Now, there are people with PSSD who, when we do their examination and they have a persistent ED, they've also fallen on a bicycle bar. So we'll see the real problem as being trauma. And the designation as being PSSD is probably not accurate in that person. So we are able to separate that population. So I mean, we define PSSD as being off the agent for 6 months, maybe having experienced some sexual issues while on the medication. But it's the persistence without explanation for other reasons. That's sort of the working way we define PSSD. You asked me about the FDA, and I sort of skirted it because this one patient is on my mind, and it's really sad. And I just had to get it off my chest and tell you. But there's a really cool advocate of PSSD patients, David Healy, and he has put together a petition to the FDA, and for whatever reason, it got lost. I don't know. It was submitted years ago. There's been really no response by the government agency on this, and I don't know what the usual waiting time is. This seems excessive, many years. And maybe with the publication, we could readdress the reality that I see a lot of it, but I don't even know what that means because we're just a tertiary center that people fly into. So it's what we see, but it doesn't mean that it's common. I can say it's not. Easiest thing I can say is if you have a condition as an individual, as a patient, where your problem is persisting, it's just simply not going away. And you weren't that way prior to the medication, and maybe on the medication you suffered a little bit, but you were explained, oh, that will just go away. But now it's years and years later, and it's not getting better. That's not good. That to me is real reasonable evidence that we will see tissue changes in that person.
And clinically, when I guess How do you work to differentiate PSSD from other causes of sexual dysfunction, whether it's performance anxiety or kind of a hysterical coping mechanism to sexual problems or something like that, without an ultrasound? Because I understand that maybe a lot of clinicians out there don't have this kind of ultrasound. How would you look at it in teasing the two out if you didn't have that type of tool that could see that tissue damage?
Well, then that's the rub. Because these patients had, well, in general, most people who have PSSD that I see have had normal function sexually prior to using the medicine, but have had some mood issue, some mental health issue that's requiring the use of the drug. So that's where the confusion wraps in, because they are requiring a medication, they have a mental health issue. So it's so easy to say, oh, well, you are on Lexapro, you have a persistent problem. It's clearly that it's the mental health issue that is, you stopped the Lexapro, but your original mental health problem is what's causing this. It's just not. I mean, it's just not that way. Our data, which are based on so many issues, a HOD will be able to give you we have international index of erectile function scores of control populations, of trauma patients, of the vascular risk factor people versus the PSSD people. We're seeing, so in the field of sexual medicine, we have the ability to ascertain the severity of the ED with really nice patient-reported outcome measures, highly validated. The International Index of Erectile Function is what, in fact, Pfizer used to get Viagra across the finish line, Cialis across the finish line, whoever the group that did Levitra. It's divided into no ED, mild ED, moderate ED, and severe ED. And if we take sort of the cohort of individuals with the PSSD and look at control cohorts of other people who are equally aged, 20, 30 years of age, our population it has severe ED, way high percentage compared to the usual population of 20, 30-year-old ED, which is very rare, but it's all trauma-based in general, versus the elderly people who have severe ED.
How is
so it's not just the tissue change; it's the severity of the problem that is an issue.
Could you speak to maybe the type of the character of the ED that you would see in depression or severe anxiety, and how that might be different from PSSD?
So it's a great question. The ED in depression is mostly one of low interest, low wanting to have sex. I have no libido. I'm exhausted. I'm tired. I have no energy. I'm black. I'm gray. I'm not very excited or I'm not very sad. I'm just blah. So that's their version, but that's not the PSSD version. They'd love to have sex. They want to have sex. They can't because the machinery is not working, and it's very frustrating. And they've been medically gaslighted for so long, being told that it's all in your head. It's not like that, and I'm just thinking out loud here. It's probable that those with depression, the usual sort of mental health version or psychologic version of ED, would be more associated with, I get morning erections, doc, I'm just not interested in using them, and when I'm with a partner, nothing's happening, and blah, blah, blah. But these guys with PSSD who have the tissue damage, they do not have normal morning erections. They have sad, very partial versions of morning erections.
And the other thing is, gosh, I lost my train of thought for a second. I wanted to ask about.
It gets personal when you do this stuff.
Yeah, the general anesthesia. What do you make of this common symptom that I hear reported, that it feels like they've lost erogenous sensation, that kind of sexual type of feeling that in the genital area, and then people say that
extremely common.
Yeah.
It's a pleasure-free area. I mean, they may or may not have orgasm, but if they have it, it's fairly muted. And the pleasure, the joy, the fireworks that follows ejaculation orgasm is just missing. So I attribute that to a different sort of nightmare of these PSSD agents. So the nightmare that I talked to you with the oxygen radicals, that's the effect on the erectile tissue that causes the inability for the tissue to function normally. But there's another aspect. The exposure of SSRIs to the brain, its job is to raise serotonin. And God knows what else it does, but let's say at least at some level it raises serotonin in the synapse, which is an amazing inhibitor. But why do we assume that when they stop their SSRI exposure, that everything readjusts back to its preliminary value? Why can't it be that their serotonin levels and maybe other abnormalities associated with the agents continues to exist? Because if you bring that up, you're bringing this concept of excess inhibition in the sexual process. And let's argue that absent pleasure, absent feeling is central nervous system inability to record pleasure. You've inhibited the idea of whatever pleasure ends up being. And let's say it's very largely dopamine and norepinephrine and probably oxytocin. Whatever you're doing at that fundamental neurotransmitter level, the serotonin is inhibiting it. And
I mean, that idea makes people very uncomfortable. But we have clear analogies of this happening with other drugs. Namely the antipsychotics, which are very well known to inhibit kind of movement. And for some people, they'll have these, tardive akathisia, where long after the drug, the movement systems in the brain are still disruptive, and sometimes it doesn't go away, but sometimes it takes years to come across.
Of that, and I think that's a fabulous example, and I think that's what's happening.
Yeah. Another thing I wanted to ask you about was something.
Listen, let me just say, I'm not against SSRIs, okay?
Sure.
In appropriate situations, they save lives. There's no question. The suicide rate, we've had patients commit suicide. It's awful. And if SSRIs do that, I think where I fumble with medical professionals is their inability to provide warning, like appropriate consent to these products. Parents giving this to young people, where we see this frequently in my practice, but no one's giving consent that this may happen to their child. They may not wish to expose people to that, or at least provide an appropriate consent so that if it does happen, they don't have to spend 10 years being medically gaslighted, and they could go get correct help as soon as they can.
Yeah, I completely agree with all of that. It, as a risk, to me, it certainly weighs on the risk benefit, and it would, and when this comes out and people are more aware of it, I think it will skew who we give these medications to people who have more severe depression and anxiety, because that would be the cases where you would accept a risk like this, and not for kind of garden variety heartbreak or things like that.
So yeah. I don't know if a HUD ever tells you a HUD's world, or if other patients that I've seen who have been in nice relationships with partners, something happens, the partner breaks up, they're a little bit sad, they don't function as well as they ought to. It's 100% situational change in their functioning. It's extremely common for them to go to hims or hers, or God knows how they achieve these crazy things. No doctor being seen, little phone call, little telemedicine, reviewing the risks and benefits, but not discussing PSSD. And they're on the medicine. I mean, it's not that complicated to get this medicine anymore. So people who have situational situations, who should be counseled, are getting these dangerous brain-altering chemicals that can affect tissue integrity for the rest of people's lives. It's crazy.
Do you have any, I'm just going to throw this out there. Or actually, no, I'm going to ask you this first. So you mentioned that you can inject medications into the penis to help with an erection, and that the people with PSSD, sometimes they need such high levels of this to even get anything. Is that, if someone had depression or anxiety and you gave them one of these chemicals, you would expect them to be quite responsive to that, right? Because
we would give them very low amounts of that because their tissue is working.
Yeah,
it's their libido, it's their detachment, it's kind of their mood thing. They wake up with normal erections. They're showing that their system is working. It's just when they interact with others that you're not getting the function that they want.
Sure. Making a segue now, because I want to really use all the time I have with you. What can you say about the prognosis of this condition?
Yeah, so that's extremely important, and I think the way to do this best is to say that I have no ability to reverse this as if the person had never ever taken the medication. So if they have a sexual issue, I think the most honest thing I could say is I can help them get better erections, I can help them get better orgasms, I can help them have better life quality during their sexual function. But it's not going to be like it was. It's going to be like they're going to need to do stuff to improve their erections. It's going to be to do stuff to get better pleasure and orgasm. If they're willing to do this stuff, I could help them so they have a better life quality. And if you speak to many of our PSSD patients who have, it's kind of like loss. You go through the 5 stages and finally you get to acceptance. You say, okay, I don't want to live like this, so let me do things to help me, versus how angry I am that when I was 5 years old, my parents prescribed this for me. And you got to get over that eventually. But once you get through into acceptance and are willing to work with us, and we can help them a lot, but we're not putting them back to the pre-PSSD days. It's not going to happen.
And could you briefly just walk through what a treatment plan looks like for someone who has PSSD, the types of things that you would try to, as you mentioned, improve their sexual functioning?
So it's a pansexual dysfunction. So it's not just ED, although ED is a very prominent one. And there are PSSD people who have totally normal erections. So it's a 100% individual thing. And I'm sure there's a lot of genetic susceptibility to all of this. And that's why we can't really predict this, because I am sure the majority of people who take SSRIs have none of this. The problem is there's a whole bunch of people who do have this. So for ED, we do ED things. So there's kind of symptomatic treatments and disease modification treatments, and we would take them through the various conversations for those. For people with low libido, we would, of course, measure their hormones, and if there was any contribution from a low testosterone state or a low dihydrotestosterone state or an elevated sex hormone binding globulin state, or sometimes we see hypothyroidism and sometimes we see high prolactin. So, there are other versions of low libido other than testosterone. And if they have orgasmic dysfunction, sensitivity problems, no pleasure during what we call orgasmic anhedonia, there's an entire evaluation for that. We've seen a bunch of PSSD people who have had no sensation, who were also runners or sporting people who had annular tears in their back. before we attributed many of their numbness, lack of feelings, to actually what we call lumbosacral annular tear-induced sacral radiculopathy, a whole bunch of words.
Wow.
But for people who want to not get into medicine, they have a herniated disc and it's pushing on important nerves in their back that are sending information to their brain, and we've been able to help them get more sensation by fixing their annular tears. And listen, it's about being detective and sort of dissecting the various issues and trying to help them. Now, in addition, they have brain fog, they have cognitive changes. These are people whose memories have gone, they can't perform at work. We have doctors who have PSSD who can't be doctors because they can't function. We have people with new and worse mood changes than they had prior to them going on the PSSD, since they've come off the PSSD, that we have to work with. So it's a way broad thing, and it's way more than just ED, and it's way more than just sexual function. And we try to work with other providers who will work with us. I sometimes have to provide, there's a medication, amphetamine, dextroamphetamine mixed salt. It's really fabulous for people who can't focus anymore because of their brain fog, sort of cognitive change, and their lives change dramatically. That's a game-changing drug in that population of PSSD. So listen, we really can help people. It's a matter of not saying there's a one version PSSD that fits all. There's a lot of things that could go wrong. We need to address them, deal with them, find out the best way we can manage them and work with them. And that's the way we work with them.
Okay. I'm all out of questions, so I just want to say thank you. Is there anything that I didn't ask you about which you'd like to share with this audience?
Yeah. Like you, who work with drug side effects, recognize the good and the bad and the ugly. Drugs are phenomenal strategies that our current world uses. I mean, we now live to age 80. Let's argue that's almost entirely based on the amazing discoveries that the drug industry has made. It's just that we need to be aware that some of these agents in genetically susceptible people are going to cause them harm. And we need to not medically gaslight these people. We need to get them onto treatments and say, hey, in trying to help you, there was some issue and we need to work. I'm not an anti-drug guy. I don't want to come across like that. What I want to come across with is people who seek help because of this. They should get that help, and they should have protocols and strategies and research going on to minimize that damage. And that's where we should be. We shouldn't be in the thing, oh, PSSD doesn't exist. It's you're making it up. It never happens. It's all their mental health use. That's just wrong. That's just real wrong.
Mm-hmm. Well, thank you so much for your time. I really appreciate it.
Well, you have a great rest of your day. I'm going back to my conference.
Okay.
Thank you.
Thank you so much for coming to our channel. Watching these videos, talking about the content, telling your doctor about these things, this is making a huge impact on the way psychiatry is being practiced. And so thank you for being a part of that.